Hello, my name is Dr. J. Michael Bennett with the Orthopedic Group. I am a sports medicine specialist who focuses primarily on dealing with pathologies of the shoulder, elbow, and knee. I am fellowship trained and CAQ certified in sports medicine as well as general orthopedic surgery. As far as treatment options regarding instability and labral detachments and bony detachments of the glenoid, there's a number of different options. There's always the option of doing nothing. This is an elective procedure starting off the bat. You always have the option of conservative management. Now, with that being said, you have to know the prognosis and the possibility of going along with a conservative option, and that is arthritis, recurrent instability, and chronic problems within the shoulder. Because over time, the more the shoulder dislocates and becomes unstable, the more wearing you get of this little ball and socket mechanism, particularly at this glenoid, and the more unstable the shoulder can become. So what at one time could be treated with a minimally invasive operation now becomes an arthritic shoulder, and a more significant type of procedure has to be done to get long-term pain relief. That being said, typically in our younger athletic populations, we would recommend, particularly if they want to get back to full contact sports and activities, shoulder arthroscopy, where we make 3 to 4 little puncture wounds across the shoulder joint. We do 1 in the front, 1 to 2 in the front, 1 in the back, 1 out to the side occasionally. And we evaluate this glenoid. If there is indeed a detachment of that little bumper there of the glenoid, we actually put a couple of anchors. And nowadays we can actually use bioabsorbable anchors, which are actually broken down by the body and absorbed and actually become part of the bone. And occasionally they use a certain type of plastic anchor to actually pull that little bumper back down to the bone so it heals. That in itself gives you back the circumference of the shoulder joint and gives you back the ball and socket mechanism and stability that you need to maintain a stable shoulder and get back to full activities. Once again, I remind you of the golf tee scenario. You have a golf ball and a golf tee. If part of that golf tee is missing, the golf ball is going to roll off. Okay? So in the case when you have a patient that has a bony component to the glenoid, depends on the size of the bony component. If there's a large bone fragment here that's off or missing, or this side is worn down, it changes the shape of this glenoid. So it's not as oval shaped, and it's what we call pear-shaped. When you have a pear-shaped glenoid, that means that you're at high risk for recurrent dislocations. And something more invasive needs to be done, and what we usually do is something called a Latarjet procedure. And that is actually where we take this bone here, it's called the coracoid. We actually make a small cut at the base of this coracoid, and we just slide it down to wherever this bone defect is. This coracoid here is actually fixated with 2 screws, and all that does is just increase the surface area of that socket of that glenoid. So the shoulder humeral head does not slide off. Now it has another bumper it has to go across to become unstable. This is actually a very successful technique, particularly in patients that are chronic dislocators that are missing bone at the front of that glenoid surface. Okay? Now, for patients that have recurrent dislocations, that not only have that missing bone in the front, but they also have a big indention in the back of the humeral head, there's a number of things we can do with that. One is we can go ahead and fix this defect at the front, either with a labrum repair with the anchors if it's just soft tissue, or with the Latarjet if it's bone included. And then for the back, where the indention is in the back of the head, we fill in those indentions. Sometimes you can do that with a bone graft. Sometimes you can do that with a metal type of implant, such as the one you're seeing here. And all that does is it gives you back the contour of the ball. So it no longer has a big indention. That means that when you rotate the shoulder, it no longer gets caught up on this edge here. If you still have that indention in the humeral head, it can get stuck, and then you have to pop it back into place. If you don't have that indention, it smoothly rotates and gives you all degrees of freedom in the shoulder joint. Okay? So that basically describes the glenohumeral joint and the definition of a shoulder dislocation. So if you have any questions or comments, please feel free to visit my website, www.jmichaelbennett.com, or feel free to call my office at 281-633-8600. Thank you.